This scientific article is a prospective case report investigating the correlation between hamstring injuries and ilium anterior position in football players. It's an intro test the reliability of the flexion test standing and the Rygloff test. The authors was Matti Kelmann and Anders Knudsen. The promoter was Dagmar Reimagers, osteopath DO. Scientific paper to obtain the title of osteopath DO from the academic year of 2016.
Today, football is one of the most popular sports in the world. There are more than 200 million male footballers registered worldwide. Despite this popularity, there is still a serious lack of evidence-based research concerning injuries. It is a fact that the numbers of injuries in modern football has increased significantly over the last decades, with hamstring injuries being the most dominant injury, accounting for 12 to 22% of all injuries in football. To better understand why footballers get hamstring injuries, it is essential to look at the predisposing factors. Today, there are numerous recognized intrinsic risk factors. There are fatigue, age, flexibility of the muscle, re-injury, ethnic background, and the HQ ratio. Despite of the knowledge of that, the hamstring injury incidence fails to decrease and still have the biggest re-injury rate of all injuries in modern footballers. The distribution of the injuries are as follows. The biceps femoris is the most dominant injury. In the literature, it is suggested that the double innervation with separate nerves to the long and the short head are the possible cause of this. In the literature, in general, there seems to be a correlation between pelvic anterior rotation and hamstring injuries, as the pelvic position is mentioned in the literature as a possible risk factor. Studies report that a pelvic tilt in an anterior direction will affect the biomechanics of the hamstring, and these would come on a stretch. This would increase the stretch of the muscle fibers. However, there is not yet a golden standard to test if there is a correlation between hamstring injuries and an ilium anterior position. Our methodology, our H0A hypothesis says that there is not statistically significant correlation between an ilium anterior lesion and a hamstring injury on the same side. H0B says that there is not substantial inter-rater reliability between the two tests of the standing flexion test. Our H0C says that there is not substantial inter-rater reliability between the two tests of the Rygloff test. This study design is a prospective case report in addition to an inter-test reliability study. The subject in this study are all male footballers with an age over 15 years old. They have had to have previous hamstring injuries. Hamstring injuries are defined as a tear of muscle fibers by sudden overload of one of the three muscles, semitendinosus, semimembranosus, and biceps femoris. The injuries are self-reported by the footballers. Another inclusion criteria is that they have to be fully recovered after their injury, they have to have an ilium lesion during testing, and they have to practice football at least 3 times a week with 2 hours duration. The exclusion criteria are simple. It is that they do not want to participate, or they have a current pain or injury in the hamstring, back, or legs.
We did 3 simple manual tests: the standing flexion test, sitting flexion test, and the Rygloff test. These tests was performed in a standardized way taught in the International School of Osteopathy and are described in the e-book of the iliosacral joint by Luc Peters and Grégoire Lasson. In order to make the best evaluation of the sacroiliac joint, numerous mobility tests are needed. We decided only to use the 3 tests mentioned earlier, since these tests are claimed to be able to tell if there is an ilium lesion and if the lesion is an anterior or posterior direction, which is the purpose of this study. The 3 tests used in this study are commonly used in everyday practice and could serve a quick and valuable screening tool if proven reliable. We realized that in order to make a thorough osteopathic examination, we need more tests such as visceral inhibition, flare test, and pain-provoking palpatory test. The test of this study should not be seen as a complete investigation of the pelvis. The flexion test standing. You're standing in an upright position with 15 centimeters between the feet. The thumbs are placed on the inferior part of the hips. The subject bends forward and flexes his hips. The therapist evaluates the movement of hips and sees if one side moves more cranially. If it does so, it's considered to be in lesion. Flexion test sitting. The subject is sitting with his hips in 90 degrees. The therapist sits behind the subject and places both thumbs on the inferior part of hips. The subject bends forward in the hips as far as possible. The therapist evaluates if hips moves in the same pattern as flexion test standing. If the difference is bigger than in flexion test standing, the conclusion is sacrum lesion. If the difference is less, the conclusion is ilium lesion. The Rücklauf test. The subject stands in an upright position with fully extended knees. The hands of the subject are placed on the wall in front of him with fully extended elbows. The therapist sits behind the subject. The therapist places one hand on S2 and the other thumb on the distal part of hips. The subject is asked to flex the hip more than 90 degrees on the side where the therapist is palpating hips. The therapist evaluates the caudal movement of hips. The other side is tested in an identical way immediately afterwards. If hips on the side in lesion moves less caudal than on the other side, the side in lesion is considered as an ilium anterior lesion.
The dataset from this study is a distribution-free nominal scale data. We have therefore used the kappa correlation coefficient to calculate the inter-rater reliability between the two testers. We have also used the Fisher exact test to calculate the correlation between the ilium anterior lesions and on which side the hamstring injuries of the players have been. In the dataset, we found only a few with dominant sacrum lesions, but since this study is about ilium-dominated lesions, we have decided to eliminate those from this dataset. This is how to interpret the kappa coefficient with the value of substantial. We have our confirmation of our H0 hypothesis. Flexion test standing. This is a data overview of tester 1 compared to tester 2. In the sum, you can see that tester 1 has found 14 lesions on the right side and 6 lesions on the left side. This is the same for tester number 2, who has also found 14 lesions on the right side and 6 on the left. However, they have not found it on the same subjects. This is a comparison of tester 1 and tester 2. In table here, which is table number 3, you can see that the sum is again 20 and the number of observed agreements are 12. This is 60% of the observations. The number of agreements expected by chance, which means by luck, is 58%. The kappa coefficient is 0.48. This strength of agreement is considered to be poor, and we have to accept our H0C hypothesis. In the Rücklauf test, the number of observed agreements was 12. This is 60% of the observation. 38% of the observations are by chance. The kappa coefficient is 0.355. The strength of this agreement is considered to be fair. The result shows that we have to accept the H0B hypothesis. Table 5 shows the correlation between ilium anterior lesions and hamstring injuries. We have used the Fisher exact test to compute the two-tailed p-value, which equals 0.01. In association between rows and columns, this is considered to be statistically significant. The result means that we can reject our H0A hypothesis since there is a perfect relationship between ilium anterior lesion and hamstring injuries on the same side. This result is significant.
The findings of this study suggest that there is a correlation between hamstring strain and ilium anterior lesion on the affected side, at least in the cases where the tester agreed on the ilium position of the subjects. However, our results is compromised by the fact that we could not rely on the flexion test standing and the Rücklauf test. The inter-rater reliability was not good enough for that. The correlation between hamstring strain An ilium anterior lesion could only be seen as a tendency because of that and because of the small group of subjects. For future studies, it would have been interesting to make a cohort study with subjects with and without ilium anterior lesions and perform a follow-up to see the prevalence of hamstring strains injuries after a given frame of time. In this study, possible bias would have been limited experience of the testers with a mean age of 4 years of using the test of our choice. The number of subjects could also have been bigger. It was not possible though to find more subjects who matched our inclusion criteria. The testers was not double-blinded, meaning that the testers knew the purpose of this study. The testers might subconsciously wanted to find ilium anterior lesion in order to prove the hypothesis. The self-reported hamstring injuries could also be a problem, meaning that we needed to rely on the subject's ability to remember if they had a proper injury. The ilium lesion happened after the hamstring injury could also have been a problem. The results of this study show a statistically significant association between ilium anterior lesion and hamstring strain. The integrated reliability in the flexion test standing was poor, and the integrated reliability in the Rücklauf test was fair. The findings of this study suggest that a screening of the iliosacral joint might be helpful in order to predict and ultimately prevent hamstring strains among football players in the future. More reliable tests than used in this study would be preferable in order to detect ilium position. The poor and fair integrated reliability found in this study are similar to the results of many previous studies. This is why special emphasis should be taken in order to strengthen the reliability of future iliosacral mobility tests.